Had some break? Okay. So let's go on, proceed. After this marvelous introduction from Professor Saad, we always call Professor Saad the gate opener. She always opens the gate of everything good. And the ultra marvelous presentation and short resume of what's the NBAS and what's the NBO. Let's be more local and discuss our practice in Egypt. How did it all started, and where are we standing now, and our hope for the future. Are we ready for the tour? I always love narrating stories. You say so. You always say so. I narrate stories. I don't give lectures. So let's see how we reached this day by being here in this place and discussing the NBAS and NBO practice in Egypt, and how we managed to bring the NBAS and the slogan of the NBAS to the pyramids and to the museum. This is yesterday, and this should start like 2015 back in the same place with Professor Saad and Rita and Joanna, when we attended a very, very informative and life-changing workshop. Like minor and small acts do, when they are really sincere, they do matter, and they say it changes people's life, and one of these life are mine. Thank you again. Thank you, Rita. And after this workshop, it was an introduction like that we had today. But what's the behavior of newborn, and how can we interact? Is there a tool to assess the stress of the newborn, the tool to interact with, or they're just حتة لحمة حمراء, as we used to say in Arabic. حتة لحمة حمراء means a red meat that not reacting, not having memory. That was the previous perception. And ever since this, I clinged to both. Lucky me, Rita, and Professor Saad, and the journey all started ever since. Because of those two magnificent ladies, I went to Cambridge. I had my training in Cambridge, 2018, and if you can observe, who's this pretty lady here? This is Ingi, like 5 years or 6 years ago. I had the training there, and we had some obstacles. They told me, okay, another Egyptian. By the way, we have 4 previous Egyptians who started this, but no one finished it. That was so enthusiastic, and I had the push. But why no one finished it? Because of the logistics. I'm not a doctor in the UK. I don't have the, I'm not allowed to practice there. And we are here in Egypt, or all the experts or over the borders. You're supposed to have video film the NBAS and the NBO and send it. This is not acceptable in our community. Not many families would accept that I would film and video film the baby and the practice and send it to the 25 cases. We need to have 25 cases, and that was an obstacle. Then comes the COVID, and I planned to go in the UK, and okay, I will do it anyway. We have some pioneers. Dr. Sara started, Professor Saad started, but someone needs to finish this to have an Egypt on the map, and I was stopped. I will confess, I stopped. Time till God sent us Rita. So it's the story of people in interaction with people. Rita voluntarily decided to come in Egypt like once or twice a year to train us and to be our mentor. Thank you, Rita. She kept coming to our center, seeing patients, teaching me, teaching other doctors, picking the future NBAS and NBO practitioners, and we will always be grateful for you. This is total volunteer work. We should please thank Rita for us. Afterwards, because it was COVID, there was no way. Afterwards, we had the first NBAS certification in Egypt, thank God. Then comes the bursaries. The bursaries are al-minha, the completely sponsored bursaries came after. Lucky you. So every year there are 8 bursaries all around the world, and mashallah, because of the very, very strong CVs you're all posting, we always have 3 or 4 out of 8 each year for Egypt. Yes, and thank you for your support. And that again was, and this is no compliment. The fact speaks. The effect of Ingi being on the head of Basildon, and we owe you this as well. So we have many now NBAS and NBO practitioners in practice, we are increasing the number. First, we had Manar and Marwa certified. Yes, Dr. Manar Muntasir, Dr. Marwa Taha. We always training couples. So this was the first couple. Then Aya, Dr. Aya Shabana, and Dr. Fatma Al-Zahra. Next couple. So we are now 5 certified NBAS practitioners in Egypt. And inshallah more to come. These are them. The demographic data of the doctors here is what shapes the Egyptian experience. It's totally different from NBAS and NBO every otherwhere in the world, because we are 100% pediatrician. All of the NBAS practitioners are pediatrician. 80% of them are neonatology consultants, like all except Dr. Marwa is a pediatrician. All other than this work in the NICU, and keep this in mind. And 80%, all except who? Manar. She's a brilliant lactation consultant, but not, sorry, neonatology consultant, but not a lactation consultant. So 80% of us are lactation consultant at neonatology, and keep this in mind. This would shape our future. Hopefully, we have more subspecialties, but this is the current situation. Then comes the NBO. We have also 5 certified practitioners, Dr. Rahma, Dr. Nada, Dr. Rihab, and only the last month, Dr. Sarah Al-Miligi and Dr. Nashwa Shaltut. We are 5 NBO certified practitioners in Egypt now. And again, 80% pediatrician, not neonatologist, and 80% lactation consultants. What a coincidence, yes? And they are all marvelous. So there's something peculiar about our experience here. Why don't we have like what Ingi showed? She showed us like there's occupational therapists, psychologists, psychotherapists. We don't have such occupation in Egypt that are in direct contact with neonatology, our neonates in the 1 or 2 first months of life. That would shape our experience. It directs us to a place that nowhere, it's not common. I mean, like many psychologists, therapists, psychotherapists would love to, and we would love to have them. But the point is, where would they see the patients? And where would they give the service afterwards? And that's the question that many of you ask me on the group, the WhatsApp group that we're making. Why is I'm not accepted when I apply for the NBAS? Because it's important to tell me, where are you working? Do you see actually newborn? Yes, we all have the intention. We have the feeling, the passion, but do you see newborns? Can you deal with them? How are you going to impact later? Can you transmit the knowledge? Or this is not a dead end or something that we cannot propagate? This is the answer of the hundreds and hundreds of questions I received on the WhatsApp group after every time we apply for the bursaries. So that's the secret. Where do you work? Why are you do you want to practice the NBAS or NBO? And how are you going to impact the future? We're having the responsibility of being the head of the spear, the head of the arrow. Everyone now is opening doors for the coming generation. That's a responsibility. So then we proceeded with Dr. Dalia Hashad. Dr. Dalia Hashad is now in the States. She's not with us today. And translated some pamphlets. I do have them that Ingi kindly showed it in the presentation. We translated some pamphlets into Arabic to be given to parents, especially the post-NICU. And this is tomorrow and after tomorrow, inshallah. Inshallah, this is an achievement. Again, thanks to Rita, Ingi, and Professor Saad. Very thankful we will have the training here in Egypt. It's a bursary. The first 12 doctors in-person training, and this would be transforming the experience to another limit, hopefully. This is the group, or the page of the Facebook that we made for contact, for spreading knowledge, for any updates of the information. Kindly, if you're not on it, join us to catch up with the information. And these are some words. When yesterday, or 2 days ago, I asked the group of the practitioners here in Egypt, what do you feel about it? Dr. Sarah Miliki, where's she? She's always the first responder in everything. She's the active head of spear in many subspecialties. She said, I believe that everyone has the right to be well observed and monitored. And no one is rather important than the newly born. Thank you, Dr. Sarah. That's the spirit. I can now observe them, monitor them, follow up with the parents. And she says a story of her mother, she did the embryo, yes. She said it was a 2-week-old baby, And the mother said, I can understand him now. It's all about the anxiety. I don't know how to deal with the baby. Why is he crying? How can I calm him? All the questions in the mind of the mother will answer. And this is a typical scenario. Ingi showed us the statistics. They are all satisfied. The doctor is happy and the parents are happy. For me, it added the piece in the puzzle. Yes, I'm a neonatology consultant and a lactation consultant, but there's something missing. Why do we have twin babies? One accepts breastfeeding and the other refuses. They are twins, same circumstances, same mother, same amount of milk. Why would Ahmed accept and Ali refuse? We have many patients that we follow in our clinics as neonatologists or pediatricians. Before entering the NICU, for whatever reason, sepsis, delayed also sepsis, jaundice. And I see the baby before, and I usually do the NBAS to all my patients. Not for scoring and recording and research, but I integrate it in my practice, my daily practice. And I know my patient before the NICU, and he's for the NICU for 2 to 3 days, and he's a total different personality. How can we deal with them? How can we understand what is he saying? That's what the NBAS added to my practice. So this part was introduction to who are we, where we came from, where we stand, and what are we aiming at in the future. Let's talk about some practice. How we apply it actually on the ground. These are some of my patients. There are tens and tens and tens over the 5 years of NBAS and NBO assessment done. And these are all consented, with written consent from the family. And the doctor here smiling. This is the mom of Omar, one of the double agents. She's a doctor and a mom. We usually use our colleagues. And Dr. Abir is the baby in blue, is also the son of a doctor. Most of them, who would accept being filmed other than a doctor. Other than this, we're stuck. That's why we can't send videos. Again, thanks to Rita, we did it, thank God. The field of actions, what are the actions or the fields that we apply? And within Egypt, as I told you, it's a peculiar nature of NBAS and NBO practitioners because most of us are lactation consultants, neonatologists, or pediatricians. We deal with the previously called demanding, clingy, needy, fussy, or lazy. There were a stamp. This is a stigma. He's the demanding baby. He's the difficult baby. And afterwards, we discovered, no, he's telling us some messages. He's trying to communicate. He's the good one. In breastfeeding, for instance, someone tells me, this is the best baby I had. I have 3 boys, and this one is the best. He always sleeps. He's not fussy. He's just fed and put in bed. And when I weigh him, he's way below the weight gain. But he's not complaining. But for the parent, he's the peaceful, perfectly growing. Yes, I hope all my children was like this. On the contrary, when I see a fussy baby, struggling baby, crying baby, this is the worst of all. But he's struggling for life. He's doing so because maybe he's holding it in an improper way. He can have 3 reactions to this. When the mom carries the baby in improper latch, in a proper position, like when I'm in a properly positioned lactation position, I suck and swallow. When the mom carries the baby belly up, he's always breastfeeding like this. They react differently, and that's what we saw. They react differently, like when we are in a job, and the manager puts us in a queue and yells and shouts. Maybe the doctor would hit him and move away to leave the job. Maybe another doctor will say, okay, I need the job. I will just endure. Some third doctor would say, okay, I will wait till I find another job. Yes? And some won't complain and would find another job. He's fine with the struggle, he's fine with the healing. These are 3 different reactions to the same insult. The manager insulted all the employees, but everyone acted differently. This is what happens with breastfeeding and every insult in the way. But now we understand them. One baby would just strike, no more feeding, even if there's no alternative. I don't need a bottle, I will not eat. The other one would just keep going, poor grower, till he has a bottle. Then now I found an alternative, I don't need to breastfeed anymore. The third, he's not complaining. The apparently peaceful kid that keeps going on, but no weight gain. That's exactly what the NBAS and NBO enlighten our brain. They are actually reacting to something. They are mirrors to an external stress. We're starting to understand them more. So no more stamps like lazy, demanding, fussy, or sleepy calm. Now we understand. We have a deeper understanding. This is the piece of the puzzle that was put. Then infant who refuses breastfeeding and fussy at breast with no organic host, the milk is okay, everything is okay. What are you fighting for? What's the problem? Then came the adoptive families. Do we have many lactation consultants here in the room? Oh, mashallah. That half of our practice for adoptive families, the induction of lactation. One mom, she's not a mother, never was pregnant, never gave birth, and she adopts a baby and she wants to breastfeed him. In our culture, this is the only safe. There are many ways for adoption, but if I adopted a boy, when he's grown up, he's a stranger to me. This is not legit in some views. How can I live with some stranger? If I adopted a lady, a girl, my husband is a stranger. So the safest, they don't have to do it, but some want to do this, is to breastfeed the baby. So he's now my son. Milk kinship is a son of lactation. So these moms were challenged because she brings a baby she does not know. God knows what he saw in utero, the 9 months, the experience, the fetal programming that he's been through, and at least 3 months in the Ador, the adoptive, the place where they stay, till they can go home with the adoptive family. This is a challenge. I started seeing these babies when we visit the orphanages before the babies are taken to the new family. And then that's when I saw the difference between babies. I saw the extremely stressed, anxious, angry, and not reacting at all. I saw the extremes. In our clinics, we usually don't see the average baby. The average baby, the 2 caring parents bring a baby for lactation. This family is caring. But when I saw the orphanages, I saw the extreme. And it worked like magic. When the adoptive family brings it before it's going to home, and we work with the baby, we do the NBAS, and we give them some information how to deal with them, how to organize themselves, and then act with the baby, it was a transformation. And we could see it not only with the NBAS and NBO, we could see it on the growth chart. They grow smoothly afterward, though they are eating the same amount of food, same volume of formula in the orphanage, and same amount of food at home, but transformed because they got the key how to deal with those newborns, adopted baby. Then a major that we challenged the doctors of GIT, gastroenterology in pediatrics, when they diagnose infant colic. Yes, we've been dealing with infant with the diagnosis of infant colic. You know the infantile colic? Pediatricians here, please raise your hand. We always say the crying baby that cries, we used to say 3 hours a day, 3 days a week, 3 weeks a month, this is an infant colic. Now we are having a different perspective. We can understand him more. It's not just, okay, it's infant colic. Then the babies of mothers with postpartum disorders and anxiety, depression, the mirroring. And this is a great field that Professor Saad opened, the maternal infant unit here. How can we deal with the mother who were previously stressed, have some traits, and when the trait, maybe she's somehow obsessed, it's an obsessive compulsive disorder, somewhat disorder, it's exaggerated because of the stress, or maybe disease relapsing. Now we can deal better with these mothers because we use the baby as a calming when they communicate in a good way. We use the baby as the key to calm her, the oxytocin of breastfeeding. These are our fields of the NBAS and NBO here in Egypt if we're discussing our experience. And then comes the mega event. The project that I wish that would be standardized in every NICU in Egypt. The program of post-NICU rehabilitation. And that worked like magic. I have many advocates like Dr. Karim, here's Dr. Sarah, Dr. Aya. I know we are in the room, but this should be a standard care. Any child ICU should automatically be directed to NICU rehab, and I will talk about it. And that's where we use the NBAS and NBO marvelously. Again, all these add on any patient, any newborn would benefit from NBAS and NBO. We do it for bonding, for a happier family. It helps parents understand their newborn baby more, interact more easier, bond, happier results. And this is a bag that Ingi showed me. It's the bag, one of the bags of the Brazilian training. They always put books in bags with messages. So it's not just a bag, you're walking around with a message. So this bag had happiness is communicating with your baby. Yes, and this is a life-changing for many families. So these are our partners in the NBAS and NBO. We're not calling them patients, they're not patients. More doors to open. If this is the field of practice of the current NBAS and NBO practitioner, because we are lactation consultants, neonatologists the most, but hopefully when we expand, we have psychologists, psychiatrists, maybe some days we have occupational therapy, we don't have occupational therapy in the NICU in Egypt, maybe that would open new doors and bring us new horizons, hopefully. If I would quickly say some examples of our patients, the lactation medicine, what has the behavior assessment to do with the lactation medicine? Why is it that helpful? We're always grateful because a lactation consultant who is a practitioner of NBO and NBS is something up next level. In lactation, we say this is a process of breastfeeding. The process of breastfeeding is a team effort between mom and the kid and the environment, the dad or the grandmother or so on. So mom produces milk, then the proper latch, we open the way, and then comes the infant. The infant should want to breastfeed, and now we understand that he has something to say about it. He's not a piece of meat, he's not a bowl that we fill with milk, he is an active partner. So the baby should want to breastfeed and can breastfeed, can like the muscle power. If he's in a NICU for a long time, we do rehabilitation, physical rehabilitation for the baby, for the suck muscles, for the whole body. And what we're talking about now is he's wanting to breastfeed. It's mind, muscles, and energy. If he's a cardiac patient, septic patient, he cannot breastfeed. This is not our scope now. But if everything other than wants to breastfeed is okay, then comes the NBAS and NBO. This is the same pyramid, but I restified it. Physiological stability, motor stability at what we deal with in our NICUs. He's physically free. His blood pressure, temperature, heart rate, respiratory rate, okay. Then we start talking about the behavioral state organization, the attention, the interaction, the self-regulation. We need all these to finally reach a breastfeeding baby. It takes a village to breastfeed a baby, that's it. An infant colic, I told you. Previously, we're saying any baby who's crying 3 hours a day, 3 days a week, that's Whistle criteria or whatever, the Rome 4 criteria. I don't know why is he crying. Then I stamp and give him the diagnosis of infant colic. And what's the treatment of infant colic? Reassure. Reassure whom? A crying baby and a crying mom. Families would collapse. Mother would get nervous breakdown. The family, they may get divorced. Reassure mom, this is just 5 months and it will pass. 5 months, like 5 long whole months. It's not 5 months, but this is what happens, isn't it? Yes, we just say, okay, he's infant colic. I have nothing to do. It will pass. But the word "it will pass," this too shall pass, as we say it. This too shall pass is what the books advise us to say. The literature, the gastroenterologists, the Rome 4 criteria, which describes this is a crying baby for no known reason. Known reason. Now we know better. Okay, so shall pass. Where? Above the mom, above the family, below the family. Shall pass is not a reassurance. Till this period passes actually, many catastrophes might happen, and it is, thank you for the video. It's the first experience that shapes me. It's like a soft dough, a soft clay. We're shaping the baby now. The trust versus mistrust theory of development, psychological development. We are dealing with, are these parents understanding me or not? How can I trust them if I'm angry and they think I'm having colic? This is the first pillar in the psychological development. Well, Erik Erikson, see, I'm looking to the psychiatrist here. Erik Erikson stepwise, the ladder approach. If the mom, like 5 months, is not understanding the baby, he's sad, he's angry, he's afraid, he can't organize, and okay, it's colic. Put plugs in your ear, put mute button on his mouth, like the pacifier. In Arabic, we say the pacifier is sakata. Sakata means the muter. It mutes the baby. I don't hear the noise, but it is inside. That's where the NBAS and NBO pain. So this too shall pass. We should, before diagnosis colic, thinking twice and think behavior. My dream, post-NICU rehab program. Who's a neonatologist? You're all double and triple agents, yes? Okay. After NICU discharge, he's totally okay, he's growing, everything is okay, and when he's with his parents, they come back maybe 2 or 3 days, and he's sleepy. I don't know what's wrong with him. He's fussy. He's crying all the time. He's mottled. What do neonatologists think when a mom says he's always sleepy? We think sepsis, septicemia. Then we admit him again and do lab tests, X-rays, and we separate them more from the parents. We don't have parents staying in an ICU currently, unfortunately, that's a common practice, but they are separated, and more anxiety. And poor activity, poor suckling, they don't cry for feed, sleeps, too fussy, or the apparently nice baby who is smooth and angelic, but no weight gain. And what we say, neonatal sepsis, we admit there's no enough milk, give formula. This is not true. It's not about the volume. Yes, you agree with me now. Or what in Arabic we say, سيبوه يجوع وهو يرضع, like leave him. When he's really hungry, he will feed. ده أنت بتقهره, ده اللي هو لما هزله, يعني لما تجوع هتجيلي. لا, this is more insult when you don't understand me, like leave her, she will stop crying. Like cry out. That's how we deal. Yes, either readmit, give formula unnecessarily, or leave him cry. It increases the stomach size. This is the culture. When babies cry, maybe it increases it's good for the diaphragm. We find any reasons to assure us that it's okay. This too shall pass. But how? Where? Okay. And this is heartbreaking. Now it's more heartbreaking to me. Now we see the sleepy as coping mechanism. He's just, just like the adult, flight or fight or freeze when he faces something strange that he can't cope with. Habituation, I'm not just ready for interaction. You're not choosing the proper time. We have sleep cycles. We have alarming signs like I'm ready for interaction. I'm not ready for interaction. This is too much. Maybe many people are just cuddling and they're happy I'm back from the NICU. This is too much now. We know, and we teach the parents the alarming signs, so she can know when to interfere, when to play, when to feed, when is the proper time to call me on phone. A virgin. Some babies are just afraid not of breastfeeding, of touch, because all their experience in the NICU is pain. So when a nurse, a doctor, whoever opens the NICU, the incubator, what would he do? Cuddle and touch and sampling, instrument, a Ryle tube, per rectum temperature, loud sound. This is a torture. So he is used to what? Whenever someone is going to touch me, pain. So he's aversive to touch, not to breastfeeding. She comes to our clinics and says, my baby does not want to breastfeed. No, he does not want you to carry him. He does not want anyone to carry him. This is a step before talking about the breastfeeding. We know how to just carry the baby, touch the baby, interact with the baby. And this is what we do. Who taught this? Us this. You understand, NBO? Many papers about the psychological impact of NICU. Many papers. We can never deny it. And even the doctor, if the doctor and the nurse was angels, or maybe the mother and the aunt of the baby, it is a bad experience still. Tamam? The stresses, we can enumerate stresses till tomorrow. We can count many, hundreds. And what if you asked a newborn, can you tell me your experience about being in NICU? What do you think he would say? If he talks, actual talking. If he can remembers and write down how he feels in NICU, even the best of NICU, was the best doctors and first nurse. What's this? An isolated prison. Instead of being carried in the tummy and the uterus 24 hours, 7 days a week, hugged, with food, with temperature control. Now I'm in an isolated prison. No one touches me except for pain. Yes, no one is here. This is the practice, unfortunately. The exception is when we find an ICU that does skin to skin. And again, how many of you, because many are, you're answering the question before I ask, doing the skin to skin. Yes, but I'm a neonatology consultant. Every new doctor coming in the shift, every new nurse, what's this crazy consultant? Yes,
the
and
mother come and they say
the parents refuse sometimes. The nurses refuse. Yes, they are afraid. They can't. No, they cannot refuse. It's orders. No, this is not allowed. They won't refuse. It's the team. The doctor. Yes.
No, the culture is changing.
Sure. Now we're doing it. In Arabic, I was in charge of Haddana. Haddana is a neonatal ICU in Arabic. They said Dr. Asmاء removed the shadda. It's not Haddana, it's Hadana anymore. Mothers and fathers coming out. But it takes time. It is happening. So this is how he remembers. Does he remember? This is how he feels. Does he remember? Yes. Yes, we talked about the programming, the fetal programming, the early life programming. Yes, there are memories. He might not tell it, but this is implicit memory, yes? Am I right? Implicit memory, I should refer to the experts here. The implicit memory, this lives with me for life. And this is our turn. So this is where the post-NICU rehabilitation program came, and it is implied, and we do it, and we see the impact, and we're happy doing this, and we need to spread it more, please. Okay, dear? Okay. So the items of NICU, post-NICU rehab is the physical, for the weak muscles, okay, he's already discharged, we will claim that he's free of disease. But weak, physically weak, locally weak, and weak. Remember, I don't use the lactation as a target. It's a method of communication, it's an indicator. So I need him to breastfeed if the mom wants, for sure. So we need physical rehab and psychological rehab to both the infant and the family. We always forget. And what does the NBO and NBAS do? It helps me. After making the view black and sad, I have something good to say. Not all the infants are affected equally. Just like the employees reacted to the employer who shouted, we all react differently. Actually, we also react differently to insults. Not all the NICU patients are affected equally. Yes? The theory of the dandelion and orchid. That's why I was asking you about orchid. What's the dandelion and what's an orchid? A dandelion is a tough plant. Okay, the temperature change, the sun, the fluid, the watering. Okay, it's going. I'm managing. But the orchid is an ultra delicate creature. Just the temperature change, watering conditions change, humidity, it dies. So that's it. We have the patient, our babies, like an orchid or an dandelion. And the spectrum in the middle lies the tulip. I don't know about the tulip, but so they say, also the psychiatrist. Which baby got affected? Do we have a tool to assess? And again, assessment is the endless. It tells him, yes, he cannot organize. It gives an insight. Problems. Now we understood. This baby is screaming for help. He's not demanding. He's not the bad guy. He needs help. Then comes the solution. The first step in starting to help the baby is understanding his language, his need. Then comes the infant. This is the interactive, the tools that we use to correct, to rectify whatever problem in the program of NICU that's already here, and we are open for more ideas and more cooperation. But what we actually do is first understanding the baby, then massaging. And massaging, again, I owe Professor Saad this slide because Dr. Mona Fath Al-Bab here, she made a thesis with Professor Saad about infant bonding like 5 or 6 years ago. She won the MD, I think.
Yeah, but family medicine.
Yes, she was a family medicine, but that was helpful. Now we use her. She translated some pamphlets in Arabic. We use them with parents. And I know Professor Dr. Mona from here. Skin to skin, lots of skin to skin, during and after NICU, talking, and many papers talking about the importance of talking to the baby. The point is, the mom of a preemie who is discharged from the NICU is always anxious. She forgets to smile. She forgets to talk. Like every time she's looking at the weight, the pulse, the saturation. When he's at home, just no sound. Don't touch him. He's vulnerable. No visits. The baby is maybe 3 months and no one smiled at him at all. How would he imitate this? So talking, we encourage them to talk, to smile, to live being a mom. Breastfeeding as a tool, use the magic of oxytocin to both. This regulates the mother, and the mother, which is regulated, can regulate the baby, and we can take it forward from there. Please, another message, don't forget the caregivers. We always, as a pediatrician and neonatologist, focus on the baby, but forgot that he is mirroring the mom, who will be handed over the shift of this baby after discharge, the parents. So this, and also the NBO and NBAS helps with this. And this is the amazing twin, and I will quote from Ingi. Twins taught us a lot. This TNL, twins, the baby girls, the mom was a psychologist, and she was eager to do NBAS once and twice, and again. And she was going with my wave. She understood. And one of these twins, the lovely ladies, they're totally different. Had some problems, adverse, and she entered the NICU for 3 months, operations, and the others with the mom. After 3 weeks, sorry. After discharge, used to do NBAS for both the baby who stayed with her mother and her twin who stayed in NICU for 3 weeks, and operation and pain and total different personalities. The coping mechanism, the habituation, the self-soothing, the mooding and the cuddling. Total different personality. We used to say that one of them will be a CEO, تبقى رئيس مجلس إدارة في multinational job. I can handle, I can do it, and the other one is dependent. But the mom and I were amazed by the difference. Everyone, they're twin girls, same weight, same circumstance, but some incidents happened, which is the NICU, and it gave us 2 different personalities, 2 different persons.
Which one was the
The strong, independent one was the NICU lady. She's a lady now. This maybe 3 years ago.
I have the same experience with my twin daughters. I have the same experience. I have 2 twin daughters. They are 12 years old now.
MashaAllah.
And when they were neonates, one of them, she was in NICU, but only for 1 week. I saw this difference, that she is the independent one. She didn't want me to carry her. She can self-push herself ready.
Yeah.
The other is crying all the time and wants me to carry her all the time. I said this word, this girl is independent. She didn't want my help.
She lived alone for a long time.
Yeah.
She managed. But this is a good coping mechanism. Others would act the same. Yes. Yani, lucky her, lucky you. And I would tell you something. There's no good and bad. Both. It's about how to deal with this personality and that personality differently. You have to understand both.
Then now she is the one that I can count on her.
That's good. Then we have the long-term perspective. That would be a study if we have plenty.
I have the same with myself. I was in the NICU for 3 months.
Okay.
Myself. And I'm now a person who can handle stress and I can deal with situations, so it's
Healthy
right.
stress.
Well, it depends on what the child brings later on, right? But early experiences definitely shape, especially preterm babies, because they affect the neuroplasticity of the brain and how the brain is organized and how they react to their environment.
We are having like 20 years old experience now for being. Thank you. So that's it. And it's not about who's good and who's bad. It's about how we know her. And maybe if this strong, independent baby, if the mom didn't like, when we say, if he cries, just watch for seconds and see what is he doing. If the mom keeps carrying her every time, because poor she was in NICU and she stops the sequence of, okay, I can handle it. Because we interfered early, before leaving her, maybe she can handle it. But we don't say cry it out. This is a brief watch, like when a child falls. Every time you go and pick him. Wait, like seconds, maybe he can do it by himself. This is what we learned from the NBAS and NBO, and forever grateful for this. Okay, then our take-home messages from this. This is only the start. We have pioneers in the field, locking the door. Some who've managed to certify with the help of marvelous ladies. But this is only the start. Such a day would be, inshallah, life-changing for many. And again, I got this from the Brazelton site, the cover picture now put. If you want to change the world, start with babies. And if you want to change the world, the babies, or affect the babies, understand them. And the baby's language is his behavior. And we can trust this language. A healthy and an understood, happy baby is our goal. And do you remember this one? You gave me this. Never underestimate the difference you made. Was privileged with having this gift from them, Ingi and Rita. Never underestimate the difference you made in the life you touched, and that's what makes all the difference. On behalf of all the NICU graduates and the non-NICU graduates, I thank you all. Thank you so much.
Thank you, Asmaa.
Thank you.
For the psychiatrists in the room, would anybody guess that Asmaa is not a psychiatrist?
But the psychiatrists who made this all happen.
This is where we meet. Forget about the artificial separations and divisions and classifications. Remember one thing, a human being is a whole. احنا بقى اللي عندنا عجز to understand بنقعد نفصفص. جوه السايكاتري بنفصفص، جوه الطب بنفصفص، جوه الدنيا بنفصفص. But it's a whole. It's where really everybody meets. It's a child psychiatrist that you need. It's an adult psychiatrist for the parents. It's a human being, and that's the most important thing. What we learn from the NBAS and the NBO, from the great Brazelton man, is be humane and be human. هتوصلوا. اقعدوا بقى تفلسفوا ويبقوا عاملين فيها علم. هتتعطلوا and هتعطلوا the children. So you need to really think about the whole. So thank you, Asmaa. You are a wonderful psychiatrist. I don't know. I learned for teaching her. But really, this is where you are. Still a psychiatrist. مشي. اتعلمتوا حاجة؟ اتعلمتوا إيه؟ What did you get which was different?
For me, it's more about for me, I've been reflecting on like the amazing attitude of Dr. Asmaa and Dr. Saeed and Rita and everyone involved in this, like how you're trying to do something really meaningful, and how this is built in stones, and I've been like reflecting on how I wonder if there are studies already about like the long-term effects of these programs, and like maybe this would reduce what we see in the clinic, like ADHD and like this. I mean, we hear it retrograde, like this child was really difficult. So I wonder what a positive effect this would have on children we see.
Let's take it from now. Inshallah, 10 years later, we will discuss this study.
yes, hopefully in a good way, like with fruitful outcomes.
Inshallah.
Okay, one thing that we learned from the NBAS and NBO, this was what I like very much, we stopped saying patients, because in medical patients, but the gold standard is prevention, and this is where prevention takes place from the very early on. If we understand the kids, then maybe we don't need to treat anybody. but I mean, you will reduce the traumas and so on. And the best thing that we heard today, resilience. A negative event does not mean it has to have negative consequences. It can build a strong person. So don't get traumatized yourself when you hear or go and see a child in the NICU. They might be the strongest that we will ever have. Do we have time for questions? If anybody wants to ask a question? في حد عايز يسأل حاجة? Anybody wants to ask anyone of the speakers?
أنا بس عايزة أقول كمان في حاجة كده نورت بعد المحاضرة دي، يعني إحنا كدكاترة، يعني أنا دكتورة أطفال، ففي الأطفال بنبقى مركزين قوي مع البيبي الطفل. في الاي بي سي اس سي بقينا نركز مع الام. النهارده احنا المفروض نركز مع الفاميلي، ماما وبابا والبيبي والانتراكشن ما بينهم اللي دكتور اسماء قالته، اللي هي البازل على بعضها فعلا، مش يعني حضرتك قلتي البيبي از هول طبعا ايموشنال وفيزيكال وكله، وكمان الفاميلي از وان يونت يعني.
She was saying that something lit up after the discussion that for the baby we either look after the mother, but what is very important is the relationship, and that's what we all need to know.
You said that the NBO till the 3 months of age and the NBAS till the 2 months of age. And after that age, how can I assess the behavior?
Sorry, I just need to make sure that I got the question right. So you can use the NBAS for the first 2 months, NBO for 3 months. What do you do after that?
Yes.
You would continue to use your observational skills, but it wouldn't be using the NBAS or the NBO as such, because they are only recommended for evidence to be used from up to 2 to 3 months. Brazelton, at the same time as he developed the NBAS, also developed something called touch points, and that goes up to the age of 6 years. So if you're a psychologist and you work with babies for a lot longer, then you may want to consider doing touch point training. If you like this way of working, where you start to wonder and you use the behavior of the baby and the child to try and determine what they're telling you. Finding out their story so you can really support them. Okay? But the NBAS and the NBO is the very first approach we would use to support the baby and the parents. And really the optimal that we're working towards is meeting the baby's needs in a very appropriate and sensitive way that supports their development. Okay.
And so let me take this opportunity to ask you, please, would you start? Yes, the touch point. This is the next step. We'll take it from here because we're eager. I did it and I can probably understand it.
Thank you for all of these amazing presentations today. My question is, or maybe it's more of an observation. I'm a neonatologist and I'm very interested in neurodevelopment and development of babies generally, but this doesn't apply to most neonatologists. We're more focused on survival rather than quality of life in the future. So this is, the NBAS and the NBO are great because compared to, for example, the babies, it's a little bit easier, more simpler to use. But is there something we can do? I'm thinking from my side in our unit, what we can, some sort of a presentation or a few points, not the entire thing, that we can give people and give neonatologists, because when you're in it and you're seeing an effect of the environment or whatever's happening in the NICU in the future, because most neonatologists see the baby and then they're discharged and then someone else does the assessment, so they don't see the flip side of it or the other side of it. So I'm thinking maybe when they're aware of what's happening around them in the NICU, by 1 or 2 or 3 or just a few points that they can digest easily, be aware of how that will impact the newborn in the future. Do you understand what I mean? Like maybe something to make it concise or easy or easily deliverable to general population of neonatologists.
So there is, we're very lucky that we have NBAS and the NBO across the world. And we have a lot of passionate people who are absolutely in the same situation as all of you and want to see better outcomes for the babies that you work with. So we have a small team in Australia and Melbourne who's already developed a tool that's used in their neonatal unit, and it's called a traffic light system. And they are incredibly generous because they have developed this, it's almost like a little course that you can do online that helps everybody to think about the baby in a traffic light system way. So is this a red behaviour? Is it a yellow pause behaviour? Is it a green behaviour? And that makes me think, the traffic here in Cairo, I'm not sure you have any traffic lights, so for me it's all red. But this is actually a system that you can introduce and you yourself, because you have got the NLS, can just do a brief overview of what it is that people are looking for. And I know that Erin Church, who developed this tool, and it's free for anybody to enroll on the course, take the course, and you can implement it into your units. It would be a great start.
Awareness of this. Just
Yes.
awareness. That's the
Yes.
first step, right? To know that there's an issue and how we can fix it.
Absolutely, and they are so generous because it's not everybody who develops something and spends years doing it and then says, there you are to do well, please use it. So I can share that with you if you're interested.
I want to ask about the spread of knowledge to the doctor. Can also the score of the technique that I made with the child can be give anything to the mother, to the family for follow-up later? Because maybe the baby will not be with me the other time. For follow-up of NBAS or NBO within the 2 months as they travel, the scoring itself. Is there any documentation that the family can take for follow-up? Except the videos and the score that we have in session itself?
So the scoring is something we never share with parents because that actually doesn't mean anything. It helps us as professionals or practitioners to look at where is the baby in the development. What are they working on? What are they doing well? So we could support the parents in thinking about how best to support that baby's development. So it's not something that we share because something that's really important I haven't really said is the NBAS and the NBO is not, there's no pass or fail. And Dr. Brazelton was very clever about this. So scoring, sometimes 0, or sometimes 1 is the highest score, sometimes it's 9, sometimes it's 5. Because he did not want it to be used to sort of predict IQ or anything like that, because the NBAS and the NBO is about the individual baby. And it's not about trying to think about what's their outcomes when they're 10 or 20 or anything like that. So what we give the parents is a little written narrative of the profile that we observe together. So we document the baby's voice. This is the kind of things I like. This is the things I find a little bit difficult at the moment. And this is how you can help or support me. That's what we leave the parents with. Does that answer your question?
Thank you so much, Dr. Asmaa and Dr. Ed, for this comprehensive talk. And I think I want to tell a comment and asking something. My comment is like Dr. Sarah said, we have put the puzzle inside many things we are doing in the NICU. We doing the pain assessment scale, you know. We do the non-pharmacological measures for pain relief like cuddling and massaging, and this is the evidence-based before all of this. Thank you so much for this, and you have the passion to share with you every work. And the other thing I'm asking till we know the تلخيص أو يعني the message from you. When I always read the American Academy, and like this, when you are responding to the cry, I usually say you have to respond to the cry. When the baby cry, you have to respond. He's just calling you. So carry him, put skin to skin, or seeing if he is cold, if he is warm, if he is like this. It is right, yes. Yani it is response to the cry. It is not just the cry. The other thing about the teeth, what's your opinion? I think you pacifier. I know that the lactation consultant don't want to pacify, but on the other hand, the American Academy of Pediatrics want the pacifier to prevent the sudden infant death. And I get the message now, when the baby refuses to take the pacifier, he is stressed, and when he can take the pacifier, he is good. It is right, or you don't want to put the pacifier, or when keep the pacifier and calm him, it's wrong, I think now.
Okay, so there's kind of two things here. There's something about crying, listening, feeling, hearing the cry, and then there's something about pacifiers, sucking. So first of all, I just want to share with you that Dr. Brazelton always said, and I can't do it, it was very American, and he said, you have to learn to love the cry in order to understand it. You shouldn't be frightened of a baby crying because it's very powerful. It's a really good way of communicating that something needs to change or they need support. So we should embrace it and never try to stop it, but support the baby to feel more comfortable. We also know that sucking is a natural pain relief, and we know it's a co-regulator. So if a baby needs co-regulating, and that's a way that works and is soothing for that baby, then we absolutely support that. I guess it's when babies get older, and you see them at 5 or 6 still with a pacifier and being pushed around in a push-tay or an okay, what's this all about? But then we can't judge either, because that baby may actually, or that child may have some developmental need. That means this is the only way I can go outside the door. So it's about being open, and whatever the baby needs, we accept. But look at different ways. And the very, very unique thing about the NBAS and the NBO is when a baby cries, we stop and we listen. And how do we do that? We put the baby down. And then we wait for a few seconds to see, what are they asking us to do? What does this baby actually need me to do? We don't go and just pick them up and start rocking them or giving them a baby. Those of you who have got babies here, you already know your baby, but for that newborn baby, if we don't stop and listen to them, then we create a habit. There's nothing wrong with that habit, nothing at all. But it's not necessarily listening to the baby and what they need. And sometimes they just want to hear a voice. Sometimes they do want you to put a hand on them. Sometimes they do want you to pick them up and rock them and give them something to suck. All of it is okay, but we allow the baby to tell us what they want us to do. I don't know this baby, and it would be so disrespectful of me to just go and pick up a baby that cries. I should stop and listen to them first and ask them what they would like me to do. Okay.
It's a conflict. To solve this conflict, first, the lactation consultants are not totally against the pacifier. It's just till the baby learns how to latch, then it's okay. So it's not other sides or enemies. And again, the pacifier is a soother, like a painkiller. We are all allowed to use painkiller, but as a painkiller, not as a treatment. We say that hand sucking is that we give scores for the baby who can soothe himself in the NBAS. Like if he can brings the hand near, sucks
Did he succeed to put it inside? Could he call himself, this is something good that we'd like to watch, and we don't leave him for many time, long time like crying. He's just like, when he falls, you observe, is my child going to pick himself up? What is he doing? He's struggling. Okay, he's doing it. He's doing it, then okay. Or just I need to stand beside him and say, okay, get up. Or maybe I have to carry him. That's the same. We're not leaving him fall. We're not leaving him cry. And we just observe it purely, shortly, and I will complete and stand where you. Or else, the strong baby for the NICU would have ruined this coping mechanism, the good part of it. So the pacifier, yes, it soothes the baby. And we should act, if you allow me to say that, share this, as the Panadol, the paracetamol. Not use it all. This is not a treatment. I know we call it حيلة الغلبان, the method of the helpless. Yes, I need to calm him, but what was behind the cry? That's the message. Understand why is he crying? Until we solve it, soothe him, give him painkiller, but not as a treatment. I hope this is justified. The lactation process is not totally against, and we are all speaking one language, but different perspectives. Thank you.
Thank you. I think there is a celebration coming soon. Okay. So we'll take this last comment and then we will do the celebration if that's okay.
Thank you all for this amazing thing you've been like yesterday. So I just need to inquire about the training itself. Is NBO like a prerequisite for NBAS or they don't work parallel? And you said it's 2 days training. So what's next? What's after the 2 days?
Sorry. Yes, I should have said that. So with the NBO, my babies complete some paperwork and send it to the Practitioner Centre where it's evaluated. And if you pass, then you receive your certification. So it's slightly easier because it is an observation. The NBAS, you attend two training days, then you go on practice. You also attend some mentoring sessions, and we can do some midway kind of support where we look at you administering the NBAS, and when you feel confident, and we ask you to practice on somewhere between 20 and 30 babies, depending on your experience and confidence in handling babies. Then you can say, yeah, I'm ready for certification, and then we arrange a day where we actually watch you do the NBAS. There is a reliability that is quite strict, but it's very achievable, and we support you through it. So it's not something that we would ever want you to be scared of or frightened of, because it is that we want you to pass it, and we'll make sure that before you do your certification day that you are actually ready for it. So yeah, so it's a journey. It's a really, really exciting journey. I mean, I did mine 20 years ago, and I still now, every time I do the NBAS or NBO on a baby, I learn something new. It's so exciting, and I just feel very privileged and lucky to be able to work this way with babies and parents, because it just creates such a wonderful room.
And in the NBO or the NBAS, they are not prerequisite to each other. One can start with the NBAS, one can start with the NBO. NBO is easier, that's all.
The NBO is 18 items, so yes, it is a lot easier. So if you wanted both, then do the NBO, because then you know sort of 18 items, you know the sort of background about Russellton, then you can do the NBAS. But it's up to you. I have a very, very lovely friend from Denmark who said that when she did the NBO training, which she did first, it was like she walked into the room with no glasses on, and she walked out with these massive glasses where she suddenly saw the baby in a completely different way. And then she did her NBAS training, and she said, now I've got a magnifying glass. You actually start looking at babies in a very, very different way. It makes you stop just acting, it makes you think, because you start really seeing the baby in a different way. Okay.
Before the celebration.
So,
the way.
we have a few celebrations because we have got some people who recently certified. So we would like to just give some certificates to some very special people. Have we got Sarah?
NBO.
I'm going to lose this one.
And then we've got Nashwa. Dr. Nashwa, okay. She's certified in NBO. Well,
It's yours. Okay. Congratulations.
we've got Aya.
Yes.
Yes.
And then we have the latest, Fatma. Last Friday.
يعني wisdom.
Yes.
Did she fit with you?
I normally have a lot in her clinic. So.
Okay, you're good.
Can I do it separate?
Yes. Are you going to meet her?
So these are, they've certified, but we need special thanks for certain people. First of all, Sword. Thank you very much. And she took us to see Elmore Street on Moore Street. And she showed me bubble for two. So she's been the bubble for two for Cairo.
Yes, exactly.
And then the next one we need to thank is Marwa. She's been an absolute tower. She supported every trainee that's come by. I've got a lot to say too. And last but not least, that fireball there for Dr. Asmaa. She's already certified, but for me, alhamdulillah, from my dream, she will carry that plane.
Yes.
She's training to be a trainer, so Inga supporting her through training. And inshallah, I am getting older, yes, I am, Sarah, and she will take over and
I know what's inside already. We call it the Olympics flag, and that's the baby person. I got it. I saw it.
So
And that's the
baby.
I'm a Brazilian baby, of course. So this is the flag. We will pass it over to generations, hopefully. Yeah. Yes. Thank you.
Okay, thank you all for coming.
Thank you.
Shall we have
Thanks, Jackie.
Oh, please.
Yeah.
Can we have
Yeah, why not?
can we have a collective photo for everybody?
So who do we get to take a photo? Do we get somebody to take a photo?